And here we go. Okay, let's get this thing started. So last week, I started the topic of therapeutic alliance. Why do you think I did that? Why would I, yeah, tell me. Why would I start?
Foundation, building a foundation and trust you and keep coming back in.
Okay, that you described what is therapeutic alliance, but why would I start with that? Yes. It is the best predictor of a good outcome. You will likely see that on a test and on your boards forevermore. It doesn't matter what pill you pick or what therapy you use. Therapeutic alliance is the best predictor of a successful outcome. And then thank you for telling us what therapeutic alliance was. Now, I gave you some strategies as to how you can elicit and generate therapeutic alliance. What were some of those interview techniques we talked about last week? Let me call people off my list here. Is Kevin Wong here? Hi, tell me, what were some of those ways we talked about eliciting therapeutic alliance? Well, that's the goal, yes. What are some of the interview techniques I told you about last week? Think about it. We'll come back to you. Yes, tell me. Motivational interviewing was one of the techniques. What is motivational interviewing? Yes, tell me. Using open-ended questions for what purpose? Why do we want them to do that? To elicit their own goals? That's right.
What they should be doing. They're more like people should be doing.
Exactly. Whose motivation are we talking about in motivational interviewing? The client or the therapist? The client, right? So we're trying to elicit the client's own internal motivation to make the change, whatever the change is, right? Okay. What else can you tell me about motivational interviewing and how it compares to, say, do what I say? What are some other strategies? Yes? Right. So if you allow them to speak freely, you may be able to figure out what the barriers are that are getting in the way of making the desired change, right? Good. What was another interview technique that I mentioned to you last week? Kevin? Tell me about the bathe technique.
How they feel emotionally. What is troubling the patient, their current concerns,
Mm-hmm.
handling or what the patient, how the patient feeling with the stresses of the way,
Mm-hmm.
showing empathy.
Showing empathy. Good, good. Who wants to say more about the bathe technique? Anyone have anything to add about that? Yes, ma'am. Tell me. Right. Exactly. Why are you here? Well, my dog died and my mother had a conniption and my father went to jail and my son is doing these horrible things and you got a pill for that? No. So what you're going to do is you're trying to focus in on, of all those things that they said, which of them troubles you the most? Well, the fact that I can't sleep. I can do something about that. Right? That's good. I can help you with that situation. Yes. Trauma-informed care. What is that? You're assuming that someone has some kind of trauma. Does that mean you need to dig up the trauma and go through it line by line until they're crying? Okay. Right? Don't believe that we have to have crying in order for good therapy to unfold. You don't want that. They have to go home. You got the next patient waiting, right? What do you need to do before you start eliciting people's traumas? If you're going to do that, yeah. Right. Figure out their coping mechanism. How are you going to peel this person off the ceiling and bring them back down so that they can go home safely? The last thing you want to do is send someone out of your office in emotional distress and say, now go forth and drive on the interstate. Right? You don't want to do that. You want to make sure that the coping mechanisms are in place. Good, 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 good. Now, one of the things that you're doing with motivational interviewing is you're listening for some key things. What are you listening for? How do you know they're ready to make a change? How does anyone know? Oh, hi, nice and loud so I can hear you, please. Show some interest in what? Ah, good. They start to ask about the logistic questions. That's right. So there is a mnemonic in your notes called DARN. Have you seen DARN in your notes? Desire, ability, reason, and need. So you're listening for the client to express to you their desire for change, their ability to make the change. You're listening for them to give you reasons to make the change and the necessity, the urgency of the moment. One of the questions they do in motivational interviewing is called the importance ruler. And then the other one is the confidence ruler. So the importance ruler is you say to the patient, on a scale of 1 to 10, 10 being very important, 0 being nah, how important is this change for you to make? And they're going to say to you, I don't know, 6, 7. Now, it's very important you ask them, why are you not something lower? Don't mess this up, otherwise you blow up the therapy. Why you're a 7? Tell me why you're not a 2. What you will do in asking that question is you will start to elicit from them all of the reasons that this is so important to them, so that you have a language to mirror back in their own words why they're even coming to see you, right? So on a scale of 0 to 10, how important is this change for you to make? And they say a 7, and you say, why aren't you a 2? And then they start to give you their reasons. The other one is the confidence ruler. How confident are you that you can make this change? You see, one of the biggest problems is this whole self-fulfilling prophecy, right? There's a thing called self-efficacy. Who can tell me what self-efficacy is? Yeah, tell me. Exactly. The patient's belief in their own ability to enact whatever change, therapy, et cetera, is going on. It's the belief in their own ability. So you want to enhance that self-efficacy. How confident are you that you can make this change? And then they say something like, I don't know, a 6. And then you ask, why not a 2? And then they'll tell you why they are so confident. Well, because, I've done hard things before. I climbed Mount Kilimanjaro. I run marathons. I've gone to graduate school. I can do hard things. So I'm confident I can do this little trivial thing you're asking me to do. Good. You're building self-efficacy and you're getting their vocabulary. You're learning their language, which you will then use to mirror back to them when you decide to make, or they decide to move ahead with the change. What was the big question I told you that you're basically going to start any therapy with? Why is me giving advice bad? Yeah. What are you willing to do? They will only do what they are willing to do, what they want to do. People only do what they want to do. So in the same vein, you need to realize that, yeah, I want to do this, but clearly I'm getting some sort of gratification in not doing it, right? So what you're doing is you realize the ambivalence is normal. It's normal to feel 2 or 3 ways about a particular situation. Do you want to stop drinking and gambling? Well, yeah. Well, why haven't you? Well, because all my friends do it. Oh, I see. So if you don't drink and gamble, then your friends were not going to be around, or you'll have to make new friends. Well, yeah, and then I'll miss them. And I've been drinking and gambling for so long, it's kind of like what I do. It's part of my identity. People think I'm cool. So now you have to think about, well, there's a lot of reasons to not make the change. So then why are we here? Well, my house is in mortgage foreclosure. My wife is going to leave me. The dog won't talk to me, etc. Right? So those are the reasons. So what you're doing is you're capitalizing on that ambivalence. That is normal. You need to validate that. Now, the other thing you need to keep in mind is their value system. Do you want me to think of you as a drunk gambler? Well, no. Well, you're acting like a drunk gambler because you're drinking and gambling. Well, who do you want me to think of you as? Well, I want you to think of me as a responsible member of society who does this, 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 and that. Got it. Let's talk about the discrepancy then between your ideal and how you're living your life. And so you want to exploit the discrepancy between what they aspire to and how they're currently living. Do professional nurse practitioners act the way you did by diagnosing someone on television? No. Then why would you do that? You see, that violates your professional value. You don't want to, people will live better if they live in accordance with their own values, and you're trying to clarify to them how they're not doing it without judging, condemning, and pointing a finger. You kind of want them to arrive at that conclusion on their own. Okay. Any questions about motivational interviewing and the like? You got it? The notes are there. You can even do a little exercise with your favorite LLM. You can say, I want to practice my motivational interviewing skills. So let's practice around a patient who has a problem with fill in a something. And then it will interact with you back and forth. You can practice motivational interviewing with your chatbot. That's fun to do. Okay. The other thing is, what did I tell you about mental illness last week? What'd I say? I didn't say there's no mental illness. I said there is no thing called mental illness, right? It exists, obviously. Hello, we're all here. Look around, you know. But there is no thing called mental illness. Why do I make that distinction? Say again? Right, you cannot empirically verify the thing. All I can see are the results of your behavior, but I can't even say it's mental illness until what? Rule out everything else, right? Okay, good. So let's review the 6 steps to arriving at a diagnosis. Step number 1, rule out what? Factitious and malingering. What is factitious? Yes, they're both faking, but why are we faking? Hold it. Yes. Right. Factitious, you're embracing the sick role. That is your goal. What about malingering? External reward. That's the distinction. So step 1, rule out factitious and malingering. You're not here for a note, are you? You're not here for benzos, are you? You're not here because you're lonely, are you? Right? Factitious and malingering. Step 2, rule out what? Substance induced. How do you do that? How do you know anything in psychiatry? Ask them, do you use drugs, including marijuana, cocaine, etc., kratom, ecstasy, fentanyl, whatever the Z thing is that's on the market now, ketamine, all the drugs. And of course, we're going to do a toxicology screen, right? The only way you know anything in psychiatry is how? You got to ask. It's the only way we know. Psych is for psychiatry, not psychic. You have to ask. You have to ask everything. What was the technique I told you to ask questions by so that they don't feel judged and persecuted and put down and miserable? What? That's the implicit model, not quite. That's good. We'll talk about that. But what did I tell you? It's in the Carlat book. Louder? Normalizing. Yes. Normalizing, right? Assume everything and assume nothing at the same time. Yes? Yes. Right. You want to enter into a relationship where we don't know what it is we're treating when the cannabis could be causing the altered mental status and we're going to give them an antipsychotic? Oh, okay. Here's the deal. Your drug test is supposed to be confidential in a traditional setting. It's non-forensic, right? You're not reporting to some authority, but you can't really help them until you outright tell them, look, I'm trying to help you. And unfortunately, psychiatry is a diagnosis of exclusion. And I cannot exclude things until I check. And part of building this therapeutic alliance means I have to trust you and you have to trust me. And since I don't know you from Adam, the standard of care is that I do a toxicology screen on you to make sure that whatever is causing your distress is not something that we can treat by just simply stopping a substance. Go pee in the cup. Just like that. I'm not doing you any favors. For what you're paying me, we don't have time to beat around the bush. Do you want me to lie to you? Do you not want me to give you good care? Do you just want me to hand out antipsychotics and some would say yes to the benzos? When really the problem is maybe it's alcoholism, maybe it's cocaine, marijuana, etc. Look, if the marijuana is legal, it's not going to affect your licensing, is it? Oh, with the VA, it's not because it's federal. Right, all right, well, it's federal. You know your environment. Then look, change jobs or stop using marijuana. What do you want me to tell you? No one's forcing you to work at the VA or any other federal entity. Come to Cornell, where you're resident and you're a nurse. Maybe I don't know. I mean, come on, that's just. I'm actually horrified that we don't have a mandatory drug-free workplace in healthcare of all places. Do you want your surgeon high? Let's wing it. No. Oh, wait till we do psychopharmacology. So here's the conundrum. You were in psychopharm. What's the difference between alcohol and marijuana in terms of clearance and metabolism? Where is it stored? And might that fat-soluble marijuana that's released over time have psychoactive properties? Can you possibly be high and feel normal? Can you be buzzed and say, I'm fine, I can drive? You mean to tell me we're relying on your subjective report when I can clearly see there's a psychoactive substance in your body that says it's still here? Do you want to sign someone's ability to go drive on the street like that? I'm sorry, what? Oh, I got it. What's the component in the energy drink? Caffeine? Okay, well, that's not as psychoactive and psychotic inducing as marijuana, is it? Also, it's a legal substance, right? Also, no one's killing each other over Celsius, and it's not laced with anything. Although they might be when they accidentally put the alcohol in the Celsius. Remember that happened over the summer, actually? Oopsie, put alcohol in the Celsius. Yeah. Suffice it to say, marijuana lingers. And I don't know how long it lingers. Everyone clears at a different rate. It is fat soluble. That's the biggest problem with marijuana. How many people are somewhat high and still driving down the road, right? So you can play devil's advocate. When you get out of here, that's your license on the line. By all means, bless them and sign the paperwork that say you can drive high. There's a word for it. The kids have a word for smoking marijuana and driving. I forgot what it's called. But when I was commuting to White Plains on the FDR Drive, stuck for 2 hours, just kind of go 1 mile. And I sit there and the windows are open. Why do I smell marijuana sitting on the FDR Drive? Because the guy in the car next to me is smoking a joint to pass the time as we're driving down the road. Kind of scary. Kind of scary. So suffice it to say, yes, you need to do your due diligence and you have no way of knowing if they're not intoxicated. Or if toxicology is the culprit, if the condition is substance induced. Step 3, rule out an underlying medical condition, right? Because what if your symptoms are underlined by some medical condition that we should treat rather than palliate with a psychotropic medication, right? There are people with undiagnosed anemias and lead poisoning and hypothyroid and diabetes and heart disease and adrenal issues and, so you have people out there doing, okay? What if they're just generally deconditioned because they haven't done anything in God knows how long? That is an underlying medical condition, and that might be the reason for your fatigue and listlessness, etc. Okay, so once you've ruled out the underlying medical condition, then you go to step 4. And what's step 4? Adjustment disorder, right? Let's make sure that you are not possibly having a normal reaction to a chaotic life event that will probably resolve in the next 6 months or so. Okay, and then finally, step 5. Pick a primary psychiatric diagnosis. And as we go through this, I will drive home the fact that you want to go after the sleep issues first. So make sure that the insomnia is contended with first before you go after things like inattention, anxiety. Also, you want to make sure you get done with the PTSD part before you start labeling attention deficit disorder, given how common trauma is, because a lot of those symptoms can overlap. And the last thing you want to do is give some anxious person a stimulant. Okay, yes. Oh, well, it's an adjustment disorder. So they rise to the level of symptoms that are characterized in the DSM. It's causing some impairment, but it's going to be short-lived after the voted upon time period. Something. Right. And when you say step 6, you mean establish the boundary between no mental illness. Right. So note the boundary between no mental illness is that it's not affecting the domains of your life. It's odd. I'm not used to seeing you do this. I'm not used to seeing people talk to God out loud, but it's not affecting anything, you know? So no mental illness. I'm not quite acclimated to your proclivities, fetishes, and kinks, but it's not a mental disorder because it's not interfering with the domains of your life. It may upset somebody, but to each their own, right? We don't want to pathologize something prematurely. And why do we have to be this careful? What's the problem with psychiatric diagnoses? The big ones anyway.
Follow your problem.
They follow you through your whole life. They're very sticky. It's hard to undo them. Once you buy that label of schizophrenia or psychosis, it's really hard to get off of any sort of paperwork. Unless someone methodically goes through and you say, oh, look, all of my psychotic breaks were only due in the setting of, say, alcohol binging or marijuana or cocaine or whatever. And so maybe my issue is addiction and rather than psychosis, but that's going to take a relationship and consistency to figure out. Okay. All right. So last week we talked about how to elicit the information and the systematic approach to proceed in a manner so that you can get the information you're looking for. Now, the question we have today is, well, what is it that you're listening for? And that's the overview of today's topic is what is it you're listening for? And the reason you have to listen in an organized manner so you can organize the information is because you need to figure out where your intervention is going to work. So, what are some things you may want to elicit from your patient? Yes. Their family history of mental illness. So we like to organize our information into 3 domains. So here we are, we say we're going to do a biopsychosocial formulation or assessment, right? So if we're talking family history, knowing that we have to listen for those 3 domains, biological, psychological, and social, what are some things regarding the family history that you may want to elicit, say, in the biological domain? Yes. Right. Family history, mental illness, there may be a genetic component. What else might you want to elicit? Biologically, yeah.
Like I really didn't know.
Mhm.
There are things studies that show babies over that have problems with birth with lack of oxygen.
So about them in particular, about the patient, about your birth history. Okay, yes, fine. Absolutely. That's a biological predisposing factor. Yes.
Diabetes.
Right. General medical conditions, diabetes, thyroid, adrenal, etc., right? Stroke, heart disease, whatever. So maybe you hear that, oh, dad had a stroke at 45. File that away. That might be handy later on, right? What else do you want to elicit? What about psychological or social in the family history? What do you want to elicit there? Substance use, yeah.
Suicide?
Suicide in the family, yeah. Yes. Childhood traumas, that whole ACEs, right? The adverse childhood events. File that away. Psychological predisposing factors. What about socially? Socio-environmental. What sorts of factors might you want to hear about there? Yes, sir. Nice and loud. Say again. Say more. Oh, economic background. Yes. So what the social, how might you ask that? How much money do you make? No. How would you ask that? No, the family. If you want to get to the socioeconomic background of the family, yes? Where did you grow up? Say more. Uh-huh. Yes? Did you ever have to worry about food or housing? Yeah? Yes?
Parents' household education.
Highest level of education in the parents, good. More social though, I'm interested in more social things. So if you pull up the ACEs or mark a note for yourself just to review those ACE scale indicators, things like, was there ever domestic violence in the home? Anyone incarcerated? Anyone go away for a long period of time? Period of separation? Did mom or dad have a boyfriend or girlfriend? Siblings, step siblings, all of that. That's good. Predisposing psychological and social. Predisposing psychological for the individual might be, what was your highest level of education? Did you miss a lot of school? Did you go to summer camp? Were you ever involved in the legal system? Were you ever in foster care or the like, right? So you want to get that about them. So that's good for predisposing factors, and you will organize that on a little grid. Now, by the way, you can do that if you work in medicine also. What are your predisposing factors that led you to have this heart attack? Let's mark those down. So that's a handy way. Now, the other thing you want to know is, and I told you this in psychiatry, we don't really have emergencies in psychiatry, right? These problems that they've told you about, these predisposing problems, have gone on for a long time, right? They didn't just happen. They've gone on. A whole lot has gone on before now. But something happened that caused them to come to care now, right? Something happened. We call that the precipitating factors. What was the thing that made you come now? So if you do general medicine, what happens is, if you ever work in the ER and the person comes at 3 a.m, I have back pain for the last 9 months. Well, why are you in the ER at 3 o'clock in the morning? What made you come now? Well, it got worse. Okay, precipitant. Right? That's the precipitant. What are some biological precipitating factors that you can name that might cause them to come to care to you? Yes. Baby. Yeah. Yes, sir. Withdrawing. Yeah. Biological precipitants. What else? Recent major injury. Yeah. Yes.
Like thyroid.
Recent endocrine condition, but hopefully you'll see the endocrinologist, but something precipitant, biological precipitant that might make them come. Yes? Yeah, insomnia. I'm not sleeping. Something happened. I'm not sleeping. I've lost my appetite, right? Okay. What might be a precipitating psychological factor? New job or divorce or loss of a job or a relationship or loss of a relationship or dropped out of school or got an F on my paper or no one's getting it. Didn't do the quiz on time or mean professor or whatever, right? Psychological precipitants. What are some social precipitants? Things that might happen in your social circle. Yes, sir. Nice and loud. Okay, bad breakup. Yeah, that's more, but yeah. Death, okay, loss. Think environmental. What are some environmental precipitants? Yes, in the back? Isolation, like for example, what? The pandemic? Yes? Yeah, social. I was canceled or shunned. By the way, we're still not original. They used to call canceling, it used to be shunning in the Amish. Whatever. Like we invented, it's a cancel, it's shun. Oh, it's worse. Yeah, other environmental things. Yeah, okay, we got that. Social, environmental, yes? Relocation. Yeah? Okay, yeah, that environmental, yeah. What about natural disasters? What about 9/11, terrorist attacks, news of, those sorts of things? You can't neglect those. You have to be mindful of what's on the collective unconscious. So if a major thing happens in society, that may have an effect on your patient. So I had a huge pop in my addiction population in men in 2008. What happened in 2008? The economic crisis, right? The housing market collapsed. And then all my well-to-do people that were trading in the credit default swaps suddenly started drinking like it was going out of style. And all of a sudden, I can't cope. What happened to you? Well, nothing happened to me except my society. Look, the company went away, the business went away, the money is now gone. Okay, those are major societal things. Okay, now, those are the precipitating factors. Now, if you ever do primary care, you will realize that about 60 to 70% of whatever walks into a primary care situation was probably going to go away by itself, whether you did anything or not. Right? The cough is eventually going to get better in 7 to 14 days. So will your runny nose. Your back pain's going to get better in about 6 to 8 weeks, whether you go to physical therapy or not, whether you get acupuncture or not, whether you take the NSAIDs or not. About 6 to 8 weeks, the back pain's going to resolve itself. Right? Most of the stuff that comes in is generally going to improve on its own because it doesn't actively kill you and it's not progressively getting worse. Now, some things do not improve on their own. And you need to figure out why. Now, from a psychiatric perspective, what you're trying to figure out is why is this problem going on? Those are called perpetuating factors. What is it about your biology, psychology, or sociology that is keeping this problem from resolving, or that is keeping this problem alive and well? What are some biological perpetuating factors? Not sleeping, taking certain meds, substances, not eating, right? The condition is untreated, right? Those are biological perpetuating factors. This is the most important category of what you're listening for. You've had me before, you'll know why. What is a psychological perpetuating factor? Continuing the social isolation. What else? Yes, your own inner monologue. What else? Maladaptive coping or ineffective coping. What about social perpetuating factors? Say again? We'd say that's probably psychological or biological because you're taking it, or engaging in the addictive behavior. What would be a sociological perpetuating? Yes. Right. What else? That's probably more psychological though. And I'll tell you why in a minute. Yeah.
You would be shelter.
In a shelter? Yeah. Yes? Say again?
Access to care.
Lack of access to care. Yeah. Okay. Although now they're seeing you, so. Yeah. Employment or unemployment. Right. How about the company you keep? Who you choose to socialize with or not so, the people around you. So why are perpetuating factors the most important thing to pay attention to? Yes? Oh, yes, because it's not so much that the abuse, it's the psychology that gets the person to stay trapped in the situation. The fear, the inner monologue, et cetera. I mean, unless they're physically restrained, but generally it's the inner monologue that you need to contend with so that they make the decision to leave. But before they do that, they have to kind of plan and do that sort of thing. So that's really a psychological issue. Social would be, the environment around you and that sort of thing. Okay, why are perpetuating factors the most important? Yes.
Because before you can, well, all the help you're trying to give your patient, unless you're able to identify the factors that negate all what you're doing, because then they just go back and keep the same sort of requirements, do the same bad habits, have the same bad coping mechanisms, while you're trying to teach them otherwise, they're sort of right back to those. So
Right. Yes,
These factors might be modified.
right. You said maybe modifiable. Go ahead, yeah. No, the precipitants cause them to come. The perpetuating factors are what? Keeping them there. Yeah. So here's the deal. You can only do something about the perpetuating factors. You can't do anything about the predisposing or precipitating factors because it's already happened. We don't have a pill to undo the past. The only thing you can work on in therapy with a pill, with an intervention, is your job is to stop the perpetuating factors. Yes? Hmm? You'll know why I said that in a minute. My psychopharm people they're nodding in agreement. They know why. I just had this little stroke for you right here. Yes? Yes. Why are perpetuating factors the most important feature to pay attention to? It's because it's the only thing you can do anything about. You can't change predisposing and precipitating. You can't change anything that happened before they got here. We'll talk about mood disorders and chemical imbalance and the like. That's called the bioamine theory, by the way. Make a note of that for yourself. Yeah. And then you can skip ahead to the notes and see what's going on in there. But we'll talk about that. Nobody noticed. That's okay. So perpetuating factors are the only thing you can do anything about. Now, why don't we admit everybody that walks in the door that makes the slightest unnerving comment? Because there's this one final P called the protective factors. And this is the thing that reassures you. This is the thing that says, I probably don't need to admit you. So who can tell me what are some biological protective factors? Yes. Yeah, nice and loud. Good overall health, right? Good physiologic reserve. Good healthy habits. Right. Those are good, yes? Good coping mechanisms, such as? What would be a good coping mechanism? Exercise? Meditation? Journaling? Square breathing? Music? Okay, good. Good coping mechanism. What are some social protective factors? Yes. Family support? Healthy friendships? Yes. Stable job? Right. Stable. A sponsor? Good. Support person? Spirituality? Yes. Yes. Good hobbies. But socially, we're looking at things like housing, employment, finances, access to care, reliable transportation to get to that care, right? Those are socially protected. Those are the reasons we don't go admitting people. Because if you can elicit enough protective factors, then you can say, okay, outpatient follow-up. But if there are no protective factors or not enough, that's oftentimes who gets psychiatrically admitted. So now, how do you know who to admit? I'm going to give you an order of operations, but I'm just curious. Who gets admitted? Yes, sir. Someone who's a harm to themselves or others. How might that play out? Tell me, sir, right here. How might that play out? Who gets admitted? Who would you want to admit? Threatening to kill themselves or someone else, right? Who else might you want to admit? You want to admit your coworkers? Oh. Involuntary. For our intent and purposes, when I say admission, I mean involuntary. Who are you going to yank off the street and throw them in a hospital? Who might you do that to? The voluntary, it's nice. They're coming for care. We'll do what they're willing to do. It's a whole different bowl of wax. Who do you justify an involuntary admission for? What about my 80-year-old lady who cannot eat or drink or feed herself or toilet herself? Does she get admitted? She gets admitted. She gets 911 to the ER. Where was she found? On the bathroom floor. She lives alone. She can't eat. She can't drink. She can't toilet herself. She gets admitted. Right? I don't want to stay. I want to go home. I know you want to go home, but there's no one home for you. Yes, what do you say? No, 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 no. Well, yes, they don't have enough protective factors. Not no protect, enough protect, right? So basically, yes? Yeah. Yeah.
Not take care of for, then again, then I thought for a second, and there's many people on the street who can't take care of themselves.
Oh, you're opening Pandora's box. Go ahead. Right.
I mean, we probably all have some kind of care of themselves. What,
They can. The people you're seeing on the street are finding some resourceful way to eat and shelter themselves. It may not be the way you like doing it, but they're finding some way to do it. They're going to the shelter, meaning they're inside. The shelter serving peanut butter or tuna sandwiches, there's food, there's water, there's a bath, right? It's available. It may not be up to your standards or what you would like to see, but suffice it to say, those very basic needs are being met. They access care when they need to. They maybe call the police if they have to. They show up in the emergency room to seek their care. It may not be what you're looking for, but they're accessing care. Yes. Right. Right. Where can they go? Or a shelter, right? It's undesirable, but even a shelter is a possibility. Now, people have a right to make bad decisions. I don't care where I want to go. I'm just going to go walk the street. You're allowed to walk the street until you start intruding on someone else's rights and liberties. Then someone is going to make sure you don't walk the street. Now, you may not walk the street for legal reasons, or you may not walk the street for psychiatric reasons, but if you start intruding on other people, you start yelling at them and pushing them and thrusting them, you're going to come to someone's attention and you're going to say, come inside. You need to come inside. Now, does that mean come inside to mental health care? Does that mean come inside to jail? One or the others, you need to come inside. You can't go out there threatening people, right? Because you're a harm to somebody else. And that's part of our admission criteria. How many of you have heard of Maslow? That's all? Oh, my Lord. I have to go way back to the beginning here. Okay. So you know Maslow level 1 is all about physiological needs, right? And physiological needs are the things that cause you to be a harm to yourself, right? So you're a harm to yourself if you're actively suicidal, right? Gashing you, that's one. If you're not eating, not drinking, right? That's a harm to yourself. If you violate Maslow level 1, you get admitted. Right? So if someone cannot do Maslow level 1 for whatever reason, they're getting admitted. Got it? Also, if you cannot do Maslow level 2, what's Maslow level 2? Safety, safety, safety. So Maslow level 2, if you're threatening someone else or you're threatening yourself or you're actively infectious, say with tuberculosis, and we know about it, you're getting admitted or arrested. Either one. But you cannot be in the circulation of other people. You're actively going to harm them. You're actively going to infect them with something horrible, right? You have to be separated from the population until we can get you to where you can then not be a harm to yourself or others. When you get to Maslow level 3, what's level 3? Love and belonging. You need a friend, right? That's where outpatient care comes in. Level 3, you need a friend, you need a support group, you need a partial hospital, you need a one-on-one therapist, a sponsor, a coach, etc. That's Maslow level 3. We're not admitting for friendship. The bar is low. We admit for physiological imminent danger, and we admit for safety. You need a friend, outpatient care. Maslow level 3, we're not admitted. Now, if you have a lot of money and you want to be admitted for that, then we call that residential. Call that therapeutic boarding school, call that, something like that. But cash out of pocket. A lot. Yes, ma'am. Yeah, same. We don't admit addiction unless you're in imminent danger to yourself or others. Now, when I say admit, remember I told you I mean involuntarily, right? I'm really just focusing on the involuntary bit here. Voluntary admission, that's a whole nother ball of wax. That's financially driven. Sometimes I have the money, I can afford it, or I'm willing to come in and my insurance will pay for it, or I feel like inpatient is, et cetera. That's different. But I'm talking about really, who do you admit? Like, you have to admit them. They can't walk out of your office. Do not pass go. Do not collect $200. You need to come inside. Okay, so that's Maslow level 3. And that was the belonging, love and belonging. What's 4? What's level 4? So, well, self 5 is self-actualization, right? What's level? Self-esteem. That's coaching. That's mental health coaching. You can do it. You've done it before. We're going to pick a new career counselor. You're going to find some purpose in your life. You're going to quit your job and change professions. You're going to go on a mission to find yourself. Self-esteem, right? We're not admitting that either. I'm in a program, a camp, going back to graduate school, whatever. Okay. Maslow level 5, self-actualization. I want to leave my mark on the world. This is how I want to be remembered. I want to make it better for you and everybody else. And we don't admit that either. You make them the professor. No, so that's that. So that is who to admit. Got it? You're a danger to yourself or somebody else. Okay, good. Now, any questions thus far? So now you know how to express the empathy and build the therapeutic alliance and ask the questions. And now you know, in general, what to listen for to make a formulation. So after you gather all of that insight, right? So what are you going to do? So then you'll get a suspicion. Then maybe you'll start to do some specific screening tests. What you don't want to do is take a pile of screening tests that happen to be free online and hand it to your patient and see what comes out. You don't do that. Because why? Well, even if they do understand it, there are some very psychologically self-absorbed people that want to take every test under the sun. Why is that a bad idea? Well, yeah, it's all self-report, but the other thing is, what are those tests? What did I just tell you? Screening tests, not diagnostic tests. That's hugely different. These are not tests that diagnose anything. Here's the other problem in psychiatry. In psychiatry, the diagnosis is made by the clinician only. There is no test that says, aha, you have this. You, as the clinician, take this robust history with a formulation, and you develop an index of suspicion, and you weed out and tease out possible other etiologies. And then you say, I'm going to land on a primary psychiatric disorder, and you select the necessary screening tests based on the formulation you're driving at, and they take it. And at the end, you say, aha, based on this information, in the absence of any other explanation, given these findings, this is your diagnosis. That's how a diagnosis is born. Got it? Now, you may need multiple screening tests because maybe you're not quite sure if it's PTSD or borderline personality disorder or ADHD. And so maybe you'll do the test to help you distinguish and lean one way or another. But even then, you might get an ambiguous diagnosis, right? And so that is a reason to refer to neuropsychological testing for diagnostic clarity. You don't always need that. Sometimes you just need more time and trust to develop, and then the patient will give you the answer. Neuropsych testing is not a fast testing process. It's hours long, days sometimes, takes weeks to get back a result. It's not jumping into the computer and hope for the best, right? It needs to be matched for like IQ and developmental, and yes, sir. Yeah, it is, except for children. So New York is great. Massachusetts is also great. A lot of states are very good at diagnosing children because we have this compulsory education. So you do, don't argue with me till I get the word out of my mouth first. As you share your experience who's starting in the program, let me share my experience who's been in the program. So neuropsych testing is generally quite good at the child level if you can access it. And the way you access it is you need really strong advocacy on the part of somebody, usually a parent, a teacher, a somebody, because the school district will do it. Now, keep in mind, it all comes down to money and resources. So oftentimes you will find that schools are reluctant to do a full neuropsych because it's expensive. And if they identify a problem, they have to treat it because we have this compulsory education thing. So this is why I told you last week that come March and April, the phone starts dialing as parents look for a diagnosis if they don't get into the fancy preschool or the fancy prep school, because they are trying to access personalized resources. So if you do get the neuropsych testing and they diagnose, say, a reading disorder, a learning disorder, dyslexia, dyspraxia, et cetera, the school now has to provide the necessary services, OT, PT, et cetera, to meet those requirements, to make it accommodative. Tell me.
Learned a lot about private care. Most parents will go to school and school will have them psychiatrist, OTPT, and that's about it. Not psychiatrist, psychologist, school counselor.
Mhm.
But yeah, but they're not gonna do like the whole 3 days diagnosis of exclusion test of
Right.
to the hearing.
Well,
spatial.
they do a lot of that stuff, but it's not done in the one fell swoop. So what happens is, depending on the state you're in, this process is broken up by multiple professionals that hopefully talk. So there's an IEP and an interdisciplinary team at the school. So the school, a lot of them will have a psychologist and some sort of OTPT in the public school system. They have this in New York. You will also have the guidance counselor, the teacher. You will have the school nurse. So the school nurse is going to do the can you see and can you hear screening. If not, go see pediatrics, get the screening and hearing. And then you'll say, well, behavior disorders. Go see the school psychologist. School psychologist say, little Billy, why can't you sit still? What's going on? You seem a little odd. Let's do a little screening test. Mom, little Billy, we think has ADD. And then mom goes to find you and demands a prescription because the psychologist said he has ADD. And then you, as the provider, are going to say, well, let's investigate further before we jump on that bandwagon. That's generally, it's a piecemeal process that takes time. Now, the primary referral to child psych is not going to be like a parent, oh, I have no clue, let me just bring you into a child psych. Most child psych comes by referral. Either the pediatrician or developmental pediatrician, if there's an underlying thing, or the school will notice a behavior. We don't want to label a child prematurely, especially, and you'll get this in your child adolescent course, but if they are not neurodevelopmentally on par, you have to make sure you've accommodated enough time to make up for, say, any sort of preterm birth issues. And also you have to dig into the household to make sure they're just not stressed out by the environment. So that's why we don't jump and label a child right away with a diagnosis, because there's no cure for dyslexia. They may not want that on their record if the dyslexia is not real. Dyslexia keeps you out of a lot of jobs, especially if you decide maybe you want to go do the military and be a fighter pilot. Can't be dyslexic if you're a fighter pilot, right? I mean, I don't know, that might be little Johnny's dream in his life. Who am I to squash the kid's dreams? But suffice it to say, you need to be careful applying, and you have to be careful asking questions that you don't want the answer to just yet. Okay? Don't just go casting a test and say, let's get a question answered. Yes, ma'am. Mhm. Mhm.
And treat them medically. Or not,
Without a diagnosis?
well, like, with like a diagnosis of, um,
Right. You could treat them for cannabis-induced psychosis. Yeah. Step one, stop the cannabis. Oh yeah, you're gonna get antipsychotics too, because who's gonna wait around for 2 weeks while this psychosis clears? Yeah, you're gonna get on them, but you may not be on them for life. During the pandemic, I had a pop in teenage-induced cannabis psychosis and hyperemesis, cannabinoid-induced hyperemesis. People weren't going out. The kids were just sitting at home smoking pot, vaping the pot, so that the parents didn't smell it. But you could vape THC without the cannabinoids. So no benefit, all high. So the psychosis the kid develops is that I think there's cancer in my body that's riddling me from the inside. I can't eat, I can't sleep, I'm talking to myself. This nonsense was going on. I said, Mom, what's going on here? Because, well, we did this last time when we went back, we got admitted to the hospital and he wound up on antipsychotics, et cetera, et cetera, et cetera. And we don't want to do that again. Well, I could treat you by telehealth, except the fact that I need to make sure you don't continue to smoke cannabis during the detox. Well, because clearly you can't keep him from smoking cannabis during the detox. Here we are. He's locked in the home, COVID pandemic, we're all locked down, and he's still smoking the cannabis. Does not anyone smell anything? I mean, how is this happening? So suffice it to say, yes, what the treatment is stop the cannabis, give the antipsychotics, give it time to wash out of the system. Took about 4 weeks. It took about 4 weeks to clear him completely with antipsychotics, and then eventually we were able to come down. So it takes a while. And then the same for the cannabinoid-induced hyperemesis. It takes about 2 to 3 weeks. But yes, and then we'll take a break. Yes?
To either like testing, who like maybe had it when they were younger, but then it's sort of lapsed and not become part of the treatment plan.
There are, but you have to pay for that. It's going to be really hard to get that covered in any other way but private funding. The other question is, what is the practical outcome from the testing? I mean, you can get it in the hospital, actually. If you get admitted and there's a question about diagnosis, it is not uncommon to have inpatient neuropsych testing while admitted. When I was at Cornell, we've done that several times to clarify the diagnosis. Yeah, you can do it inpatient, but it's very focused. Yeah. Like you want IQ diagnosed before they're adults, at least in New York, so that they qualify for all the NAMI type for the YAI type services and the like. If they get the intellectual disability only diagnosed in adulthood, it's really hard to access services. Yes.
How dancing around the ICD tech code that you do
Yeah.
with a corresponding medication, one of these every diagnostic paradigms, like.
That depends on who's paying. The whole purpose of the ICD-10 is to get the drug covered by a third-party payer. Doesn't actually mean anything if you call it this versus that. The medicine is still going to cause the sedation you're looking to cause. Depends on who's paying. Now, also be very careful in diagnosing prematurely. I think you had alluded to bipolar in a child. It's not a real thing per se. That was a whole movement at one point out of University of Massachusetts where it really upticked for a long time. And what we found was we were dealing more with oppositional defiance as well as anxiety and PTSD, but kids were buying, quote unquote, being sold a diagnosis of pediatric bipolar. In general, bipolar is something that happens in your early 20s to mid 20s, maybe 30. Yeah, right. Yep.
That they did want to diagnose
Right, but it's substance induced until otherwise dealt with. Right, that's why I said step 2, rule out a substance induced condition, because the condition can mimic some other primary psychiatric diagnosis. And if it's truly substance induced, I want to give you every chance possible to not have this diagnosis and stop the substance. That's what we want to do. Yes? So that's a big area of investigation. So if you were to ask me this in 2014 when I went through this program, they'd say, no, it doesn't. And some people are saying maybe it just unmasks what was there to begin with. And some people are saying, I don't know. Look, I will tell you, the kid that I saw, there was no schizophrenia in his family. And his issue was that a lot of cannabis in his entire developing brain from the time of like 14 and he's 16 now and basically smoking pot several times a week. So his brain has never developed essentially off of cannabis. So I don't know what to make of that. It's an area of inquiry and interest. I can't answer that definitively now, but I would not be surprised if it does not unearth something or cause some sort of adverse neuroplasticity to unfold. Yes? Yeah. Who prescribed it to them? On their own? On their own or someone prescribed it? Right. Right. Yeah. It's not. It's not. It's psychoactive. It's known to cause psychosis. So they could be used to the psychosis. That's possible. It's not helping. It's not known to create motivation and inspiration and upward mobility. You know, I walk by on the street, I'm like, smells like unemployment and despair. All right, let's take a break. In progress. Okay, guys, here we go. So now we've talked about how to formulate a case. We did the biopsychosocial presentation so that when you write your note, you're going to say something like, this is an 82 or a 52-year-old male with a history of this symptom, this symptom, this symptom for this duration, that duration, that duration, in the setting of this predisposing biological, this precipitating biological, this perpetuating biological, with these precipitating, perpetuating, protective, psychological factors. And at the end, you're going to give me a good story about who is this person you are contending with. And then you're going to come up with a diagnosis, and then you are now going to enter into some sort of therapeutic relationship where you're going to use some modality. It could be eclectic, it could be psychodynamic, it could be motivational interviewing, it could be, so how can I help you? Could be as simple as that. How can I help you? What do you want? What are you willing to do? Now, people will do things because they're convinced of certain things in their mind, and people may act or say or do certain things. For example, I gave you a scenario here. We have a 35-year-old man who presents with depressive symptoms, including low energy, poor concentration, and feeling worthlessness. By systematically exploring the biopsychosocial model, you're going to gather things from them, like, for example, family history of depression in the mother, recent diagnosis of diabetes, irregular medication adherence for the diabetes, worsening his physical symptoms, the protective factor being that he's physically active and generally healthy. And you'll do that for the psychological factors. You have this in your notes, right? You see this, what I'm talking about here. Okay, so then what you're going to do is you are going to listen for the psychological predisposing factors. And when they tell you the traumas in their life, you want to get an idea as to what age did this thing happen to you? So tell me what happened when, well, my mom and dad, they divorced when I turned 10 years old because my mother had an affair and she used to beat my father. Oh, what age was that? Well, that was, you know, when I was, say, 10 years old. So then what you're going to do is you're going to look at Erickson's stages of development, and you're going to look and see what was it that was supposed to be happening at 10 years old. So at 10 years old, you were supposed to be in industry versus inferiority, right? Interesting. So what happens is you don't have this sense of competence about you, and you seem to be this timid middle-aged man who seems to be picking the wrong people, and lo and behold, you picked out a wife who's also now beating you and also having an affair. Interesting. Where did that come from? Do you have feelings of inferiority, lack of confidence, difficult abilities, and fear of failure? And how does this manifest? Well, maybe you're avoidant of tasks requiring effort, and you have low self-esteem, and you're becoming overly competitive to compensate for perceived inadequacies. And so now, do you actually do this? Not unless you want to delve into some sort of psychoanalytic approach, but you are trying to figure out what it is going on with your client. Now, depending on the approach you take, you may go that way. Do you have to go that way to say, here's a pill for sleep? No, you don't. But do you want to engage in some sort of therapeutic relationship? And maybe this is the kind of work you do? Fine. Is this a guarantee of what's actually going on in their mind? No, there's no guarantees. All you're doing is you are offering them a theory of your understanding of their situation. And then you reflect it to them, and then you look for them to say, yeah, I think that fits. Okay, let's go with that. You're coming up with a working theory to operate onto why it is you are behaving that way. Now, why did I pick Erickson? Because on your boards, they love to test your knowledge of child growth and development by way of Erickson. So that's why I put Erickson here, so that when you elicit a history from somebody and you hear or you see symptoms at a certain age and stage in their life, and then you can figure out, well, where did the trauma go sideways early in your life? Perhaps you did not master that specific task of development. Now, Erickson's theory says you can't move forward until you master the latest task. So that might be where you will aim your efforts. Okay? Erickson was not like Freud in that Freud would say, oh, this is how you are. God bless. There's no hope. It's fatalistic. Erickson says, no, you can go back and master the task and move forth and, grow into your, generativity in your old age, essentially, so you don't stagnate. So that's one way to formulate your case as you pose a theory for whoever you happen to be interviewing and trying to help. So I gave you a list of Erickson's stages in the notes. Take a look at those stages there, because I also outlined for you what might, for example, some of the symptoms be in the middle-aged population if they are not mastering the task of, say, generativity versus stagnation. What symptoms might the person manifest to you? Right. Self-absorption, stagnation, right? They're not interested. They're stuck in their rut and that sort of thing. So this is the person that's going to show you symptoms of, say, the midlife crisis, the feelings of emptiness, the becoming overly focused on a personal gain at the expense of others. This is the one, I have to get the Maserati so that I'm feeling desirable, right? That's the midlife crisis. So you say, well, why did that happen? Well, because the person's struggling with feelings of irrelevance and I want to matter to somebody. So I'm going to engage in these sorts of things so that I matter to somebody. I'm going to wear the statement watch that you can see from the moon. I'm going to have the blingy whatever. Maybe in the female version, I'm going to have the Botox and the filler and the lips out to here, so you notice me, right? Now, we're not saying everyone that gets cosmetic procedures is having a pathology, but if someone is especially striking, when they walk in and you see the lips before the rest of them, something is going on, right? If someone is overly done up and this is a way of their being and this is where they get their validation, that could be where you ask a question and you dig into. You're not making accusations. You're going to pause. You're going to pose the theory to them and say, I noticed this is what's going on. Tell me about that. Well, I love how this makes me look and feel and blah, blah. Okay, go on. And how do you feel otherwise? Oh, I feel terrible until I get my filler. Oh, okay. And so, that's kind of what you're going at. So you're listening for where did it go sideways in the psychosexual development? That's Erickson's stages of development. And what task might they need to master? This is all theoretical. This is not something I can test in a test tube. I'm going to offer you this based on what you told me. Does that seem like it jives with your understanding of yourself? Okay, let's move forward. No, that doesn't match what you have. It's a theory anyway. What do you think is going on? You think what? You are beautiful and wonderful and great, and so why are we here? Right? Remember, you only come for problems. So, okay. Now, I gave you a list of defense mechanisms because people will say things to you and you're going to get stuck in this circle of why I don't understand. Well, you have a problem. I don't have a problem, right? So, what defense mechanism would that be? Denial, right? So can you give me an example of what is denial or a situation in which someone may manifest the defense mechanism of denial? Yeah.
Again, concerned about drinking, it says everybody I know has whiskey.
Right. So, yeah, everyone else is doing it. This is just, but why would I be in denial? What if everyone he knows does indeed have the whiskey? What's the problem? Oh, right. The drinking does not affect me. I can handle, right? And yet we're here. Okay, right. So that's an example of denial. So a person refers to behave, for another example of denial. Yes, sir.
Like,
I can stop anytime. Okay, yeah.
Loved one dies, like, so, they go loved one who dies.
Oh, a loved one who dies, right. No, they can't be dead. How about you have a diagnosis of cancer or whatever? No, I don't have it. The test is wrong. Check again, right? Interestingly enough, you may see denial start to play out in issues when you give like a diagnosis of schizophrenia. Now, their denial possibly because of the psychosis, but who else is in denial might be the mother who you're telling your 20-year-old son who is going to be top of the world suddenly has this diagnosis, which is sad because that's when it hits. And the mother may be in denial. And then she may decide to forum shop and look for another diagnosis and tell you how dumb you are for saying these things about her. It's not about you, Mom, but that's very Freudian. So suffice it to say, give me an example of projection. What is it defending against?
In your own home. Like in relationship, partner cheating when you're cheating.
Right, but really you're the one that's cheating, right? Yeah, so it helps you contend with that. So that would be a way to do projection. What's another example of projection? Yeah, Dylan, little vague. Yeah, right. But nobody's thinking about you at all. Right. Exactly. Because I'm fat, nobody's thinking about me. No, because we're all self-absorbed and busy with our daily lives, no one is thinking about you. Has nothing to do with how fat you are. Okay. Okay, let's talk about regression. This is a popular one. You may notice this in your borderline population. Who can tell me about, sorry, what's your name? Tell me about regression.
Ted.
Hi, Ted. Sorry about that. He told me before, but I forget because I get excited. Go ahead. Yeah. So by the way, I'm warning you now, I'm going down the aisle. I'm going to call on each of you for the next defense mechanism. So follow along. Ted, give me an example of regression and don't tell me the one on the paper. Go ahead.
Basically going from one going from like to another.
Going from one extreme to another. What is it you're regressing to? Hold that thought, Ted. What are you regressing to? A previously mastered stage of development, right? So who you might see regression in normally might be someone like a potty trained 5-year-old. Suddenly the new baby comes home and they start wetting the bed again, right? They're regressing back to the previous stage of development. So here's what we did. I played psychological tricks with my children. So what had happened was we had how old was he? 2. He was 2 years old. And we said, oh, the baby's coming in June. Do we potty train him now and deal with the regression? Or do we wait 3 to 6 months and potty train him after the kid arrives when he realizes there's a baby here? And that's what we did. So he thought he was the star of the show and never regressed because all my attention was on potty training the boy while my infant daughter was getting all mommy's attention. But he had a project, you see. And so we didn't have to deal with the regression because he never had it to begin with. And that was the focus. So we moved forward. So once you learn these little tricks in trade, you can then apply them to your friends and family. Yes.
Beneficial at all?
No, it's not so much beneficial. It's just a means of it's a means of calming one's anxiety. You're going back to doing something you're really good at. That's what it's for. You brought up an interesting question without even knowing it. What is it we're defending against? Why do they call them defense mechanisms? Not you. Scares you? Why do we do these defense mechanisms or why do they arise? Yeah, what do you? No. What are you defending? Your ego. You are defending your ego, right? This is very Freudian. So all this defense mechanism is very Freudian. So you're defending against your ego. And if you did not have defense mechanisms, what might happen? What happened? What if you're not ready to confront the truth? What if you prematurely confront the truth? What if a whole bunch of reality hits you at once? Psychosis. Temporary psychosis. You break down, the ego cannot handle. Right? So we are in denial to a point until we can gradually let in reality. And what you're doing in therapy is you are gradually letting in reality a little bit slower so they can tolerate it, right? So that they don't melt down and create an alternate reality, which is really what's going on with projection and denial and those immature defense mechanisms like dissociation and acting out. What they're doing is they are living in a reality of their own making, not the reality that we share. Give me an example of acting out. Can you give me an example of acting out? And you give me an example of dissociation, and you tell me about splitting, disassociation, splitting, and you're going to tell me about conversion. Okay, ready? And you're going to tell me about fantasy. Fantasy, the defense mechanism of look in your notes, it's there, then you'll come up with a new idea. Fantasy, right? And then we're going to go to the intermediate defense mechanisms, and you're going to tell me about rationalization. All right, go ahead. Go. Which one are you telling me about? Acting out. Give me an example. Someone might punch a wall. Go on, more about that. What are they doing in the acting out? What are they releasing there? They're externalizing their emotions, right? That's really what acting out is. Usually in not a constructive manner, right? Usually in some sort of reckless behavior manner. Good. Yes. Which one are you going to tell me about? Hold that thought. Which one are you going to tell me about? Disassociation. Give me an example.
So talking about another example, where we register, so losing a loved one.
Uh-huh.
React very differently.
Yes.
It's sudden, like trauma, traumatic, the whole family. We see people acting different ways. Some people are screaming, some people are saying absolutely nothing.
Numbness. Just staring at the wall.
Child, and everyone's just doing absolutely nothing. It's like how they act that way.
Right. What are they dissociating from? The reality of the situation, the truth. You can't handle the truth, so I'm going to dissociate. Go ahead, sir. Which one are you going to tell me about? Splitting. Tell me about splitting.
Patients, they end up, they're like loving all doctors, being all nurses, all the
Right. You're the only one that understands me. Everyone else, dumber than a boxer. You get me. You're the one. Be very careful. Because it's only a matter of time before you join the box of rocks. Okay? Go ahead, sir. Tell me, you're going to tell me about conversion. Tell me about conversion.
It's like having this emotional feeling of, let's say, loneliness, and then you're internalizing that, but then you're projecting that to somebody else in a physical way, like,
You're not projecting it to someone else. You are manifesting physical symptoms. And that's going to be one of the topics we talk about down the road. It's so big that it makes its own disorder in the DSM, but you are manifesting physical symptoms as a play of your emotional distress. So conversion is very popular in certain cultures. So it's not socially acceptable to have emotional distress in some cultures, but it is acceptable to have a physical complaint. That's not the same as factitious, by the way. Factitious, you are aware that you're lying and you're doing it to be in the sick role. This, you're developing. Normally, it's a neurological symptom, by the way. Usually it is. This is the person that says, oh my God, I'm blind, I can't see. Conversion disorder, okay? They have neurological symptoms, but usually it's a manifestation of emotional distress. Exactly. That would be an example of a conversion, right? So what I do with my person that suddenly claims to be blind, here, let me hold your hand as we walk by into this furniture that you see. Right, that's how I do. Oh, you're blind? Come this way. I used to work at the ER too. You're blind suddenly? Okay, come on. Come this way. Okay, you seem to miss the chair. Come this way. Well, you're missing the chair again, I see. Okay, blindness is over. Yes, sir.
Patient may be fully engaged.
Yeah.
Or.
To be in the factitious role?
Without being considered.
No. The person may be manifesting seizure-like behavior, but when you do the EEG, there's nothing to show for it. You're gonna have to work them up, but the person could then do one of these things. They could do that, right? They're only ceasing when you're looking. Yes, sir. It's in the somatic symptoms, but conversion is specific to neurological symptoms. And there is a disorder you'll see in your notes later on. We get to neurological manifestations. Yes?
Sort of seizures, like, what about they're trying to gain a method?
Right, that's malingering there. Okay. That's why we distinguished. Well, we're distinguishing here. So defense mechanisms by default are kind of things that happen without you planning for them to happen, right? It's this unconscious manifestation. This is brilliant. It's your unconscious manifestation of your inner angst. I need a pipe and a cigar at this point to do that. Okay, that's basically what this is. Yes?
Anxiety and actual, like a conversion, right? Like if you're really scared, you're gonna have like a stomach ache. Like, you know.
What's the half-life of epinephrine? You have a little drug guide in there? Do you have a drug guide on your phone? Write down, look up the half-life of epinephrine. And then you'll see. So those are episodic things. Those are very short-lived things. This conversion disorder is kind of an ongoing protecting my ego by having these neurological symptoms. Fantasy. Makes a what? Yeah. Right. Woman walks in high heels. Hi, I'm Cleopatra and I'm married to Napoleon Bonaparte. Are you, dear? Okay, maybe, maybe not. In the meantime, Your Highness, come have some cake. I mean, I don't, yes? That's a good question. So delusion or fantasy. So the fantasy can give way to a delusion where it really becomes entrenched. Delusions are things that exist in isolation. Like the delusion is very focused. It's not usually very elaborate. The fantasy comes with a whole world of creation. The delusion is usually very about one specific thing. Yeah. The fantasy could be transient until the emotional distress is over and then it resolves. Right. The fantasy is there. So defense mechanisms are there to relieve the situational distress that you're not ready to contend with. Are there more? Yeah. And PTSD, yeah. And borderlines will dissociate as well also. Yeah. You can manifest these defense mechanisms at different times. They're not enduring. They're usually transient in nature. They don't last years. Right. Personalities are constructs and behaviors that last over years across all domains. This defense mechanisms are usually situational and focused on an immediate distress. Well, yeah. Yeah. No. They believe that it's that, and they'll talk to you as if they are that, but then you realize it's situational and when the stress relieves. So one of the questions I asked you to figure out is, and I told you this last week, is and when someone manifests symptoms or a behavior, you say, what does this symptom or behavior allow to happen? Or what does this symptom and behavior prevent from happening? And so that's how you can kind of get into this. Is it a defense mechanism or is it really a delusion? You can tease that out because these defense mechanisms are all about more short-term situational distress that they're trying to relieve. Let's talk about some of the more the intermediate defense mechanisms, not rather than we'll get to the mature one. Intermediate defense mechanisms. Let's hear about, who said rationalization? Yeah, tell me about that. Right.
hard.
It's a bad professor, doesn't teach us what I need to know. Right, Brightspace didn't work and the links didn't get shared and really, right. Good. And then, so what are you trying to do with the rationalization? What are you trying to accomplish? Protect your ego. And what are you trying to do? You're trying to make an excuse. You're trying to justify your behavior with a reasonable excuse, right? Might be reasonable. So you didn't get a job because it wasn't a good fit, rather than I'm just not good for that job, right? It's the job's fault. So let's talk about reaction formation, displacement, blonde hair displacement, yeah, and undoing for you, and intellectualization for you, because that one's my favorite. Now go.
Fiction is unacceptable thoughts or impulses. An example would be like, I'm lonely, like a person that's lonely, and they'll be like, well, I really don't care if someone's not here, they really care. Or like when we're younger and like someone like making fun of or being mean to like a little girl and really like he probably likes her and like, folks like, oh, he's just doing that because he likes her.
So you're basically manifesting the opposite of the reality to make it palatable, right? So, for example, the one I gave you in the notes was where you convert the unacceptable thoughts and feelings to the opposite. You're forming a reaction so you can go along, right? So you're not bothered and ruminating over how horrible everybody is. You're going along to get along, essentially. Displacement. Tell me what that's about.
The paper target of using, well, you're a bad day at work, like, feed your dog.
Right. That's the kick the dog one. The displacement is my boss and the crap rolls downhill and you come home and you kick the dog, right? Because you can't kick the boss. So you come home and kick the dog, right? That's the displacement situation. You're trying to find an outlet for your bad feelings in a way that's socially acceptable or less offensive or less consequences. Tell me about undoing. Oh, by the way, the other thing is you may see displacement also in children. And that's not abnormal, but it's just a way for them to cope. I hate you, mommy. Why? Because mommy's safe. Mommy's going to love me even if I tell her I hate her. Right. So I'm going to just say horrible things to mommy because she's reliable and dependable and that sort of thing. Tell me about undoing. Mm-hmm. Right. Yes.
And then
Right. Because I want to undo and I feel shame and guilt about the horrible thing I did. You see this a lot in domestic violence situations also. You'll try to see undoing from the part of the abuser to the victim. Oh, look, here's jewelry. It will cover your black eye. What? What the hell? You know, so that kind of thing. So it's terrible, but you'll see undoing there. And sometimes just identifying it is helpful for the client. Intellectualization.
I are accident, then this not questioned, but asked about insurance information.
Right. Because I'm not ready to contend with the fact that you may have died in that accident. So I'm going to focus on the minutia as a means of me coping. Because my world was about to be turned upside down and I can't fathom life without you. So did you get the insurance information? What? And also, did you be sure to check the deductible and call the bank tomorrow and make sure we book the party shop and the car? So what the hell? I was in that. I'm dealing with the fact that I can't imagine what life would be like without you. That's intellectualization. Okay. All right. Now we get to the good ones. These are the ones that we want to do. And it would be nice if we can turn them on. And these you probably can turn on. So, sir, I want to hear about sublimation. I want to hear about humor from you. And I want to hear about altruism, right? From you, I want to hear about suppression highlight. Yeah. And then next to highlight, I want to hear, tell me your name. Samantha, anticipation. Ready and go.
An example of this sort of problem, somebody harbors negative feelings in their own personal lives, and they take those negative feelings and they channel it into positive behavior. So like these sports, they may use anger or like that drive and like really competitive, they have this desire to win all the time. And the work ethic because they're trying to take that.
They're trying to use it for good, right? And that's not a bad thing, to channel the energy into socially acceptable activities, right? So I wouldn't say overly competitive, but I would say making a good show, really showing up for the team and doing all the things. Not overly competitive, like I want to tear everyone down around me. It's really for general well-being and the like. Okay, so intense anger to fuel exercise, artistic. Humor, who's doing humor? Yes, tell me about humor. If you're feeling stressed at work, yes. Right. Now, why is that a good thing? Do you think it's a good thing? Do you think it's a bad thing? Yeah, brings the stress down. Does it help the situation? Does it help others? No, it helps the people around you. This is actually a good one. So these mature defense mechanisms are good things to do. These are things that are indeed useful. These are things that you should do. Yes, you have a question?
No.
Yes, they build resilience. People with good mature defense mechanisms do build resilience. You'll find a lot of stand-up comedians, especially the self-deprecating ones that tell you their life story. If you want to see a really good one, look up Christopher Titus. Watch his Love is Evil and watch his Norman Rockwell is Bleeding. Those two are where he tells the story of his life essentially and his mentally ill mother and his divorcee abusive father and the mother who shot the second husband. And yeah, amazing story, but turns it into humor. Question? No. Yes, ma'am.
Like, people have like teams.
Uh-huh. Mm-hmm.
They actually, there's like predator, potential predator who's like, both us being.
Oh, that's interesting. So is engaging in BDSM or kinks a form of sublimation? It can be. The problem is they would say that the predator is actually, well, I guess it's the same thing. They're aroused by the sadomasochistic behavior. So rather than play that out on an unwilling participant, you find a willing participant to play that out. Yeah, that could be a form of sublimation. Yeah. Yeah. And that's not too far-fetched, actually. You will find people that if they are comfortable enough with you, will let you into their worlds of kinks and fetishes and behaviors that they're doing. And then you have to be careful not to pathologize them. So this is a question I put actually in the review book because I wanted to make sure that people were reading carefully and paying attention. But I gave the example of this person who likes to go to a dungeon where he pays a dominatrix to beat him, and what is his diagnosis? And I gave you the option for fetishistic, sadistic disorder, no mental illness, and something like anxiety or depression. And I gave you the caveat that he can also become aroused in other ways. It's not the only way to become aroused. And the reason I put that line in there is because if you are only aroused by that, then you meet the definition for fetishistic behavior, which is in the DSM, and that's a disorder. However, if you can become aroused in other ways, not just this fetishistic behavior, then you don't rise to the level of a disorder and it becomes something called no mental illness because it's not impacting his life, it's consensual, it's whatever, that sort of thing. So, in order to be a disorder, it has to cause distress and it has to meet those diagnostic criteria. But yeah, it could be a form of sublimation. Who's doing altruism? Go ahead, tell me about altruism. So what is it defending against? Your own emotional loss, but also what else? Because if I'm doing altruism means what? For the benefit of others, not to the exclusion of your own well-being. Right. So it's not to your detriment, but what you're fighting against is a self-centered impulse, right? So you're creating meaning and fulfillment for others. So this would be, for example, volunteering to cope with loss, something like that. Let's have suppression. Who's doing suppression? And then anticipation. Right, suppression here, highlight, and then anticipation. Go ahead, suppression. Go ahead. No, go ahead. Yep, go ahead. Suppression's putting your own emotions aside. Go on. What are you putting aside? What does, yes, but why? Okay, okay. Because? Yes, but the point is, it's an actual cognitive, you're actually doing it on purpose, where you are saying, you are essentially compartmentalizing, I am not going to deal with this now, I will deal with this later. And the reason I make that point is because suppression is different than repression. And those tend to get conflated. So repression is, I don't even know it's there and I can't even acknowledge it. Suppression is, I see it's there, I am deliberately deciding to deal with it later. Yeah. Forget it for now. I'll deal with it later, yes?
Again, like that, you right before a party, you go.
Right.
I'll deal with this after the party. I'll go enjoy myself and act like a normal.
Exactly. Yes?
Forget it, I'm never gonna do this.
And it's not affecting you and you don't need to deal with it. Not everything needs to be dealt with. Some things you can leave behind. It's a deliberate action on your part. I was going to give a talk in New Orleans once. My wife brought our dog with us. The dog somehow decided to get on the escalator, but the toenail got avulsed and ripped out while he was on the escalator. Poor little Fluffy. And I'm about to go on stage, and my wife comes running at me with a bleeding paw dog, and this is my first national conference. I'm like, crap. So I run into the bathroom. 2 military nurses happen to be in there. The dog is whimpering and crying and bleeding all over the place. We put a pressure dressing on the dog's paw. I give the dog to my wife. You go find the emergency vet. And I run down the convention hall, run up on stage, and proceed to deliver the talk on motivational interviewing and end-of-life care. I didn't ever mention the dog's paw and the bleeding that just happened less than 5 minutes ago. Suppress that thing. Later, listen to the talk. I gave that talk so fast. I talked so fast in that thing. It was like a machine gun firing at these poor people. But the talk got out. I had good reviews. However, suppression. I couldn't deal with the dog's bleeding paw right now. There are 300 people waiting for his presentation. I will deal with it later. Yes. Yeah, but you're deliberately doing it because of the circumstances. The reason you're suppressing is the circumstances are not such that you can deal with it now. There's a reason you're doing it. It's not, I can't think. Yeah. No, that's the point. Just, no? Okay.
I think also help being in relationships because you kind of like, I'm really angry at you right now.
Yes.
The angry situation, I'm gonna step out.
So I don't say something I'm going to regret because I can't unsay stuff. Yes?
That is good.
Oh, no. I mean, it could be. Are you aware that you're suppressing it? It's the awareness, right? Whereas repression doesn't necessarily have does not have the awareness. Yeah. Yes? No, because procrastination is also deliberate to avoid contending with the issue. Suppression is supposed to be this helpful thing. You're doing something else in its place. You're doing something else. It's productive. You're doing it for a greater good. Procrastination is not for a greater good. Procrastination is merely avoidance behavior. Cognizance. Cognition. You're not aware how upset you are? Okay, it's all a matter of degree. But suffice it to say, if you are aware that you are not going to deliberately deal with this thing at this time, I'm going to do this thing instead, suppression. Repression is, I didn't even know this was an issue. Right? Okay, and the example I gave you is the act of choosing to do something different. Who's telling me about anticipation? Anticipation, go ahead. Right, go on. Yeah. Exactly. Like when you come to this class and you read the notes in advance and you listen to the podcast, right? That's anticipation so that I don't cause you stress and your stress will go down. See, that's anticipation. Very good. So the thing that's being defended against is your ego integrity. Defense mechanisms protect the sense of self from being overwhelmed and distressed by the emotions or realities. Now, emotional stability defense mechanisms, they mitigate anxiety, shame, guilt, fear, etc. That's what we're trying to not feel because nobody likes that stuff. All right. And defense mechanisms maintain social harmony by regulating the expression of emotions or behavior so that you don't go telling everyone off. You don't go kick the boss, right? That's what we're trying. We're trying to maintain peace and harmony in the world for now. It also gives a sense of control. It creates the illusion of control in some circumstances when facing a situation that you feel is chaotic or unpredictable. Now, the other thing that people contend with are cognitive distortions. Now, I gave you these grouped by function. So there are distortions that are focused on catastrophizing and exaggeration. There are some that are focused on perfectionism, all or nothing. Distortions focused on emotional reasoning and mind reading. Who would like to tell me an example of a cognitive distortion that they may have encountered? Be it in yourself or someone you've spoken to. Yes, tell me. And then you next. Go ahead. Uh-huh.
I've not, did,
So tell me about catastrophizing and how it played out in your patient situation. Right.
And I got met with preparing himself for the responsible outcomes.
Right.
So if he didn't get the job or didn't do well on the first round, he was like saying, I'm homeless.
Right. Give you the whole parade of, if I don't get, I'm homeless, no one will ever hire me, the world will end, et cetera, et cetera, et cetera. Good. Do you want another cognitive distortion? Tell me another one. Similar to catastrophizing. Is that like the funnest one? We all like to do that one because we live in New York and we're jaded. We like to catastrophize. Yes, tell me another one.
Planning. And, well, I'll get my like it says, then the world is gonna end if I were to go to Princeton, I'm not gonna.
You would think all those people are in this class right now, honestly. My emails are blowing up over people that think the world will end if they get a B. A B. No one's looking at the B. Go ahead. You're exactly right. The world will never be the same again if I don't go to Princeton. Yeah. Tell me another cognitive distortion that you can have an example of or you've encountered in your either professional or personal life.
like, FALF.
What is that? Which one is that? What cognitive distortion? Tell me the cognitive distortion you're describing. Yeah, if I have that, which cognitive distortion is that? Is that magnification of minimizing? Yeah, that's exaggerating the importance of a negative event and minimizing the importance of a positive event, right? It could just be delayed onset muscle soreness from the great workout you had the day before. No, it's ALS, I'm dying, right? That's so. Yes, do you have one example?
Yeah.
Tell me the all or nothing, because that's another favorite one.
Boyfriend breakup. Boyfriend breakup is like a real.
All or nothing. The 20-year-old with the boyfriend breakup. I'll never find anyone ever. Right? Right, exactly. All or nothing. I'm horrible. You're wonderful. I'm wonderful. You're right. Another one. Yes, sir.
The action in particular, when people have like their first break or whatever, their first admission, and they're like, if I get admitted here, it's gonna go on my record, and then I'll never be able to move on in my life. Everyone will think I'm crazy. I'll never have good relationships. I won't get a good job.
Right. Yeah, any major life event can put someone into all or nothing thinking. No, magnification minimization is one. Catastrophizing is everything is horrible. So magnification minimization is you magnify bad things and minimize good things. That's different than catastrophizing where everything is horrible and the world is going to end.
For example, the example that was given, I don't think it's a job.
Right. You didn't max it, but you just catastrophized. You didn't even acknowledge the other side. You merely outlined the catastrophe. You didn't give any other explanation. Magnification, minimization, they give another explanation, but they minimize anything good and they magnify everything bad. They're giving more. Catastrophizing is just everything is bad. Right. Other ones you can think about are black and white thinking or overgeneralization. Overgeneralization is when you draw broad conclusions based on a single event. So for example, this gives you this, I didn't get a call from this job, therefore I'll never find work. Sounds like catastrophization, but you're generalizing the fact that, but you got 3 other phone calls. You didn't pay attention to any of those? No, only this one matters. Give me an example of mind reading. And who's done this before? Yeah? Right. You assume, therefore they hate me. Right? That's it. You didn't say hello, you hate me, yes? That's right. Right. Everyone's not talking to me because of this pimple. Nobody even sees the pimple. Okay. Other ones are personalization and blaming. So everything is personal about me. Okay, that's another one there. Blaming yourself for the events outside of your control, right? And personalization and blaming is popular in the addiction cycle, especially when you're dealing with codependence, right? I drink because of you. I didn't put the drink in your hand. You made me do this, right? That's a lot of externalizing and blaming and that sort of thing, not taking responsibility. So these are very popular, these cognitive distortions and defense mechanisms. So popular, in fact, that in my first couple of years of practice, I'm like, oh my God, I'm repeating the same thing over and over and over and over again. Is it possible everyone's in denial today? Is it possible everyone's catastrophizing today? Is it possible everyone's blaming today? So then what I did is I said, okay, look, I keep repeating myself. So I went and made a personalized podcast for every cognitive distortion and every defense mechanism so that I could just send it to the patient when it's about them. So, hi, we just had a session. This episode may be good for you. Listen to that when you have time. Because in the session, they're not ready to acknowledge it, but on their own, when nobody's looking, they may be interested in internalizing that information. So they're all up on whatever podcast station you use. But if you're looking for other examples, everyone has a separate episode for it, and you can certainly check that out if you need something to fall asleep to. They're all under 10 minutes because I don't have the attention span for longer than that either. But that's all I have for today, guys. So now you know what to listen for and how to elicit the history and maybe how to pose a theory as to the developmental stage. And then you will also know to listen for issues of defense mechanisms and cognitive distortions and present a case. So next week now, we're going to do substance use disorders by Zoom. We're going to proceed the classes in the order of the steps that you need to rule them out. Those will become the next foci of what we're going to do. So next week, substance use disorder by Zoom. Log in a few minutes early so I can let you all in at once. If you have questions, happy to hear them. Otherwise, have a great week.
Good.